Reynolds Cancer Center in Detroit and Reynolds Cancer Center in Lansing, Wayne State, and Michigan State. And I'm going to talk about, or we're going to talk about relapse refractory myeloma. And I think I'll start with one of the big questions I get is what exactly is relapsed myeloma and what does that actually look like? So, and really my big thing is to try to empower you to know what's going on with your disease. Because the one thing that makes myeloma different than really almost every other cancer is that in real time you can know exactly where your disease is every month, if not every 3 months. You know, so if you have colon cancer, how do you know if you're better or worse or the same? You gotta go, you gotta drink all that stuff, go for a CT scan, you know, just a whole lot of rigmarole, and only people can tolerate that so often. How do you know if your myeloma is worse, better, or the same? You do a blood test, because 99% of myeloma patients have some type of protein that their cancer cells produce that tells you where the disease is at a particular time. So when you're first diagnosed with myeloma, your monoclonal protein, mono meaning one, clonal meaning source, protein is the protein made by the myeloma cells, is really high because when you're first diagnosed, your myeloma burden is really high. And as you go through treatment, that protein then goes down and down and down and down. And then if it goes down by 50%, we call that a partial response. If it goes down by 90%, then we call that a very good partial response. And if the protein disappears, then we call that a complete response, or sometimes we call that complete remission. There's still some myeloma there, and if you do a minimal residual disease test, MRD test, then you can look for one myeloma cell in a million normal cells. So the height of the protein gives you an idea of how much myeloma there is. The lower the protein, the less disease you have. And that's a really important thing to know, is what your M protein. In some patients, about 15% of patients will produce only light chain. So they'll be light chain producers. We use that kappa lambda number. And the kappa or the lambda will be 100 when you're diagnosed. And then it goes down by 50% to 50. That's a partial response, and et cetera. So that's how you know where you are with this disease. And I would encourage you, when you meet with your doctor, ask them, where's my protein today? Where's my disease today? Or where was it the last time that you saw you? Because that's how you're empowered to know what's going on. On the flip side, we know that the vast majority of myeloma patients, at some point, the myeloma starts to become active again, and the protein then goes up. And if the protein goes up, then if the protein goes up and you don't feel anything, then we call that a biochemical relapse. Biochemical meaning that the protein is going up, but you don't feel any different. And about 70% of patients, when their disease becomes active again, the only thing that will happen is their protein will go from the lowest point, like 0.1, to 0.4. And their protein just goes up. Or if the light chains were, 15 or 10 at its lowest point, it'll go up to 20, 25. Every time the protein goes up, the next thing to do is to check it again. Because these are blood tests. Blood tests have some error built into it. So you check it again. If you check it again and that number stays at that higher level, and it's a biochemical and it keeps going up, then you have to do one important thing. So you confirm that the protein is going up, that the myeloma is active again. The next thing to do is to say, well, do we need to do anything today? Because if you're developing new bone lesions, or if you're becoming anemic, remember the CRAB, C stands for high calcium, R stands for renal, A stands for anemia and bone disease. When the protein begins to go up, How you know if you need to do something is if you develop any of the crab. And the most likely way people will develop the crab when they relapse is with bone disease. So you got to get a PET scan. So if I have a patient and their protein goes up, next thing I do, PET scan. PET scan shows a new active lesion. We need to change therapies. We definitely need to do something different because we don't want that bone lesion to turn into a bone fracture. And we look for the other things, the hypercalcemia, renal insufficiency, et cetera. So if someone's getting more anemic, we need to do something or else you're going to feel bad. If the protein's going up and there's no bone lesions, then we can watch it. And this is the artsy part of medicine, of myeloma medicine, is that this is a discussion between the doctor and the patient. Do we need to do anything different? The protein goes up from 5 to 10, and then from 10 to 15, it stays at 15. Do you really need to do any, and there's no symptoms or signs, do you really need to do anything different? Sometimes you don't need to do anything different. And I've had patients that have biochemically relapsed but didn't have any symptomatic relapse that were at that level for a year to 2 years, sometimes months to several months, before it starts to go up and it becomes inevitable that something bad is going to happen. But that's a really good discussion point between you and your doctor, because if you say, I really do not want to watch this anymore, let's do something different, then that trumps everything else. So if you tell me, I don't want to watch this anymore, we need to change, we change. If you say, I'm okay with staying on Revlimid maintenance, and let's see if the protein goes any higher, then I'm okay with that too. But that's the empowerment part, because I don't want you staying up at night worrying about the protein. I want you to be feeling comfortable about the decisions that we make. Does that make sense? And then when finally either the patient or the disease says we need to do something different, it's become inevitable that something has changed, then we start a new therapy or we do a clinical trial. And what determines what that next therapy is what therapies have you received in the past, because it doesn't make any sense to repeat something that has worked and failed in the past in the present. And with all the new therapies that are out there, there is a plethora of treatments to pick from, and it really is what fits best for you. And I think where a lot of community doctors community doctors loved it when we only had 2 different therapies. They're like, okay, we'll just switch to the other one, and then we're stuck. Now we have so many different therapies and so many clinical trials that community docs have a real hard time picking what's the best therapy for their patient. And so what I spend, a third of my time doing is going from place to place, trying to educate community doctors on what the new therapies are, what the new clinical trials are, and what opportunities and options you can give to your patients. Because the good thing we have today is we have so many options. You can tailor the therapy to what the patient wants. I have a patient walks in, I'm relapsing, I want to be MRD negative. I'm like, okay, I can give you an MRD, we'll pick that option. Sometimes it's like, I just want the protein to get out of my way. I hate coming to the doctor, just get this out of my way. I said, okay, we can do that. And so there are lots of different therapies for lots of different patients. And now these days there's so many good therapies, so we can tailor it to what your goals are. But you have to let the doctor know what those goals are. Does that make sense, I hope? Refractory means 2 different things. Refractory means you can be refractory to a drug, where you're on a drug and it stopped working. The most common thing is Revlimid. When people are on maintenance Revlimid and then their protein goes up, you are refractory to that drug and will probably never use that drug again. You can be or refractory to daratumumab or Darzalex, or you can be refractory when you're on a drug and it stops working. That's refractory to that drug. If you're on a regimen, you're on a whole bunch of different things, and you treat, and then it doesn't work, and then you change that regimen to another regimen, and that doesn't work, then the disease is refractory, where nothing is working. And that's where the clinical trials jump in to save the day. Does that make sense, I hope? So I'm going to open up, unless you want me to talk some more about myself, I'm going to open up to questions. Any questions? Yes.
When you say, you look at the numbers, the protein numbers go up, and if it goes up so much, but how high does it need to go up for you to say, yeah, it's time to change?
Perfect. So how high does a protein go up before you need to make a change? So the International Myeloma Working Group has guidelines on that. And the guidelines is that if the protein goes up by 0.5, that's a true and true. That's true and true. So if your M protein is 0.5 at baseline and it goes up to 1, then you really need to start thinking about doing something, especially if it's in a 3-month period. If the light chains go up by 10, so if your light chain is 5 and it goes up to 15, then that's officially relapse, and you got to start thinking about doing something. If it stays there and doesn't change, no problem. If it stays there and continues to go up by 0.5 or by 10, and it just won't come down or stay stable, then you definitely need to make a change. If you go from no protein at all to any protein at all, that's also a biochemical relapse. And then you have to think about, should we do something different? The one thing I should have probably mentioned, if you have high-risk myeloma, so if you have the deletion of the 17th chromosome, if you have additions of the first chromosome, if you have one of the translocations of 14, 16, 14, 20, or 414, or if your disease was aggressive when you're first diagnosed, if it was misbehaving, causing kidney damage or other things, sometimes we won't wait. So a patient that has, high-risk myeloma, and it was super aggressive when I first met them, I'm not going to say, oh, let's just see what happens. I'm going to jump all over it because I learned my lesson when you came in that your disease doesn't play. The other patients that come in with slow-poking myeloma that doesn't move very much, doesn't do very much, if they have a biochemical relapse, then I'm usually not as aggressive. Yep. Yes.
Okay, you talk about the M protein. Okay, Dr. Morris and Dr. Zell are my doctors, right? And I always thinking that she's with the IgG. So, like you're saying the 4 and 5. Okay, through IgG, I know when it's like below 1,000, and then when it starts getting 2,000 and 3,000, because that's how I count it. Then it's like Dr. Zamler and Dr. Morris, they're on it,
Yep.
right? And so that's what I want to understand. How do you tell the amount of the M protein through the IgG?
Yes.
Because that's the way I read it through the IgG.
Super. Yeah. So there are 3 labs, 4 labs, but one of them I hate to death. So I'll get the one I hate and I don't use. I don't do 24-hour urines. I love the history of 24-hour urines. It's a 180-year-old test, super old test. I don't do 24-hour, unless I have to do a clinical trial that forces me to do it. And we're talking to the FDA about getting rid of it because it doesn't make any sense. So 24-hour urine, I don't do it. Second, so either the light chain test. The light chain test is a pure test that measures bad myeloma protein, usually. And so higher that number, worse the disease. The M protein we talked about, the SPAP, so that's the M protein, that only measures the bad protein. But then there are the IgG, IgA, IgM levels. And for myeloma patients, that's usually IgG or IgA. And that's when you're first diagnosed, that number is super high. The bad and as you mentioned, the IgG levels are a mix of bad and good protein. That's bad and good. And definitely when you're first diagnosed and the number's 10, it's way more bad than good. And so that gives you a really good measurement of where the disease is. When you've responded, then it's more good than bad. And it's a little hard to tell what's going on because it's a mix of a little bit of bad protein and some good protein. So I do the same thing, because when I do a myeloma panel on somebody, the IgG comes back first, and I'm like, okay, that's where we are today, and I get reassured. But I have to wait for the M protein, which usually comes back about 4 to 5 days later. So the IgG level or the IgA level can give you a ballpark for that, during the clinic visit, but you do have to wait for that M protein to come back to reassure that. Any other questions? Yes.
I have a microphone for you. Okay.
I think. Is it working?
Yes.
So if I have an M protein that's not, they can't find it right now, but my IgG level is above the normal range and the ratio is above the normal range, what does that mean?
It's all good protein. So if the M protein and if the M protein is normal, and if I have a cold, or if I get vaccinated to something, my good protein level goes up, or if I get stung by a bee, my good protein goes up, but I have no bad protein. So my IgG level will go up, and probably my kappa and lambda will go up. But if you do an M protein, a monoclonal protein on me, I won't have any monoclonal protein. And so the immune system is, by nature, very dynamic. I mean, throughout the day, my IgG levels, if you check it every hour, which I would not want anyone to check my blood every hour, if you do that, you'll see that it just waxes and wanes and does all sorts of stuff. When I was up at the podium, my IgG levels went up because I was stressed, and then they came down until Valerie asked me some super good questions, and they went up again. And so it waxes and wanes, but it's all good protein. That's why the M protein is so important, because the M protein tells you exactly what the bad protein is inside the IgG. Does that answer your question?
I think so, but I think I forgot to say the kappa. It was the kappa one too, the kappa ratio.
So the kappa lambda, so the trick about the free light, this is a good question. The thing about the free light chain ratio is that the free light chain ratio, the kappa also looks at bad and good in the same way the IgG looks at bad and good. We metabolize kappa a little bit slower than we metabolize lambda. So on my antibodies, my antibodies have IgG, but there's a little bit of kappa or a little bit of lambda. That falls off in my bloodstream naturally, and my kidneys get rid of the kappa slower. So if you check my proteins right now, my kappa is a little bit higher than my lambda by nature. If I have inflammation, the kappa goes higher and the lambda goes higher. So as long as they go up in concordance with each other, and the ratio between the two is still, between 2, 1, 2, or 3, if someone has kidney damage, then it's just all good protein. But if the kappa goes up and the lambda goes down, then that's bad protein, because it's suppressing the other good protein, and then you have to pay attention to that. Does that?
Yeah, that's what I was. My kappa was above the normal range, and the ratio is above the normal range. My M protein is still at nothing. And my doctor said, oh, I'm not concerned.
Huh.
And I felt I should be concerned.
So I give you, because there's a trick that happens that I really need to make sure we try to educate community doctors about. And that's called something, and there's a type of relapse that's called, and of course I don't know if it's a relapse thing at all, but there's something called light chain escape, where you can be diagnosed with an IgG kappa myeloma. It goes down, you relapse, you get another therapy, it goes down, you relapse. At some point, for some patients, when they've had myeloma a long time, the myeloma can relapse with just the light chains. So you go from IgG kappa to now having just kappa myeloma. And if you're not checking all 3 of those tests every time, So every patient that comes in and sees me for every return visit, they get those tests bundled, because I don't want to have somebody's kappa say that there's no problem, your M protein is normal, but the kappa or lambda is going up, because that can sneak, that's a relapse that sneaks in behind in the back door. So yeah, I would.
What do I do then? Just tell them I'm concerned? I mean,
No, yeah. So I would definitely voice your concern. The one way to check, the triple check that, I know this is going to sound totally crazy, is the 24-hour urine, which I hate. The one circumstance where I'm forced to do this test is the 24-hour urine can help. If I ever have a question about what's going on with this kappa lambda thing, because I give you, it's not always easy to figure out. The tiebreaker is a 24-hour urine, because the 24-hour urine will nail down what's going on.
thank you.
Yep.
Oh, now, are you talking about, you're trying to educate the community doctors? Yeah, so if you put all this data, is there a program that'll figure it out for everybody, say, well, this is happening, this is going up, this is going down, and this is what to watch for? I mean, is there something that will just do it for you?
I wish. Yeah. So I can. There's a technology coming out that will do that. So at Mayo and a company called the Binding Site, they're working on a single test called Mass Spec, and Mass Spec will be able to find the myeloma protein amongst all the other proteins. So it is, instead of doing a kappa, lambda, light chain, an SPEP, immunofixation, and quantitative immunoglobulins, that's a myeloma panel, 5 different tests. This one test will replace them all and be able to test it super accurately, almost down to MRD level. So it's way more sensitive, way more accurate, because it will say monoclonal protein, no matter if you're kappa, lambda, or what. Even if you're the 1% where the myeloma doesn't appear to secrete a protein, it can find it. The trick that they're having with it is that it's so sensitive, it picks up a lot of noise with the immune system. So the challenge is now to be able to eliminate the noise. But hopefully when that test is approved, that we'll eliminate all this, because all these tests I've mentioned, SPEP, SPEP is from the 50s. The kappa lambda light chain is from the early 2000s. I mean, these are 20-year-old tests, 70-year-old tests. And of course, the urine test is almost 200 years old. And the fact that we're using these, in my opinion, ancient tests to be able to determine what's happening to myeloma in 2024 is a bit ridiculous. But there is, I think, as soon as we get the mass spec figured out, which would be in the next few years, we'll get rid of all these tests and replace it with one. Then it'll be super simple. Goes up, bad, goes down, good. Yes?
I'm just curious, I'm in maintenance with Revlimid. If I was refractory to that, would I go all the way back to the beginning and try things, and could I try the things I did, just no more Revlimid?
So that's a good question. So so one thing that we don't do, so what a lot of folks will do is say, well, you're on maintenance Revlimid at 5 milligrams. How about I just increase it to 25? Well, that'll work for a couple months. It'll bring the protein back down, but the myeloma's already figured out how to get around the Revlimid, and it'll go back up. Plus, you'll be getting all the symptoms and side effects of 25 milligrams of Revlimid. So we don't do that. We say Revlimid, bye-bye, gone. So the next thing that we do, so we don't, and we used to go back to what you had before, when we only had 4 drugs for myeloma. Now that we have almost 40 drugs for relapsed refractory myeloma, there's no reason to go back to what you had before. So we pick something new, but that something new wouldn't be including Revlimid.
Including
It would not, I'm sorry, would not be including Revlimid.
You get a maintenance drug, or do you go back to induction?
Yeah, so we go back to an induction.
And then
So-
figure out what works in your.
Yeah, so we go back to an induction, and that induction is followed by some type of maintenance. So the second line therapy, so I should mention, a line of therapy is induction therapy, transplant, and maintenance. That's one line of therapy. And if you didn't have a transplant, it's just induction and maintenance is one line of therapy. When that fails, then you go on a second line of therapy. And a typical second line of therapy is Darzalex and Pomalyst. It's kind of your average Josephine second line therapy. And then when people go on some type of maintenance for that, which is usually monthly daratumumab and low doses of Pomalyst, but you're always on. This is, I think, the biggest challenge that we have in myeloma research is that people are always on some type of therapy, and that's the stinkos. And we've done that because, yes, it was an achievement to have people on maintenance, but now we're doing it for everyone. And now we need to figure out who can come off maintenance, who can come off maintenance, and who needs to stay on maintenance. That is the big challenge. And we're starting to figure that out, that we know the high-risk patients really need to be on maintenance. And the standard risk patients, we're working on to see who, and amongst all those standard risk patients, who can come off maintenance after a couple years. I'll go you and then you.
All right, so,
Oh,
I'm sorry, someone else? Go ahead.
no, you're the tiebreaker, so.
So last year I started on IVIG, and then I went off for the summer, and I was kind of surprised how quickly my immunoglobulins dropped after being off it. I'm just wondering what you've seen once you kind of start with that, having the trouble keeping up your immunoglobulins. Do people stay on IVIG then permanently, or is it typically a cycle, or?
So IVIG is kind of a neat thing. IVIG's been around for a long time. So when you drive by and you see the plasma donation centers, have you seen those? So what are they? What are those places? They're getting people donate blood. They donate their plasma, and inside their plasma they have antibodies. So if you take my plasma, there's all sorts of antibodies in there. Antibodies to the cold I had, antibodies to the bee sting that I had, antibodies to COVID. All the vaccinations I've had my entire life are all in the antibodies inside that plasma. And what they do at the plasma centers is they filter down to just the antibodies, and that's called intravenous immunoglobulin, IVIG. And so patients that have cancers of the immune system, like myeloma, and especially if they've had a stem cell transplant where their immune system's really low, or if they've had CAR T, and CAR T causes low normal immune system, or bispecific antibodies, where again, it destroys the myeloma and some of the normal immune systems, then we have to replace back those normal antibodies. And that's what IVIG is. It's an immune booster that's donated and cleansed plasma. It is super cleansed. So can you get infections from IVIG? No, because it is not plasma. It is purified antibodies from donors. And so it's very rare to get anything from IVIG. It is super cleansed. How often do you give it? There's two indications for it. One is if your normal IgG level is less than 300, then we usually give it. Or if people have recurrent infections, that we give it independent of what the level is. How long does it last? It depends on why it was given. For CAR Ts, people are on it for limited amounts of time, which can be months to years. But as you see the IgG level begin to get better, then you give less of it. So I've given it monthly for about 6 months. And I check an antibody level and it's 600. I'm not going to give the IVIG if it's normal. Then it'll go down, so I'll give it every other month, and then it'll be every 3 months or so. If you've had something like an allogeneic transplant, or if you're on a bispecific, the bispecific is constantly hammering the myeloma and the immune system, you may need it every month as long as you're on the bispecific. So it kind of varies from person to person and the treatment that they're getting.
Thank you.
And can I just ask a follow-up to that? Do you find that the insurers are approving 12 months of it?
Lord
I mean, my husband really doesn't have an immune system anymore.
Man, is anyone from an insurance company before I say what I want to say? Because if you're from an insurance company, you're my friend. Because I'm begging stuff from you. I just did this yesterday. I was begging. And I'm just all nice on the phone. I'm like, oh, how's your kids? How's it going? And I'm just thinking, man, but okay, I'm sorry. The insurers, I can tell you where it's kind of leaning these days, is a lot of insurers are actually wanting people to get it at home. Because it's cheaper, yeah. And that's been a recent phenomenon, so in the past 3 years, is that they know it's cheaper to get it at home than it is to get it in the office. And so we've kind of been adapting to that, but usually they'll approve it at a year at a time or every 6 months at a time. Yes?
I've only seen them approve it for a year when you go to the subcutaneous version, but I can't get my insurance company to let me have the subcutaneous version of immune globulin infusion because they say, oh, you don't need it, you know.
Yeah,
You're not,
it's a
so
headache.
I'm like, well, I'm not going off this bispecific, so I'm going to be on it a long time. Why can't I get a prior authorization that's more than 3 months?
Yeah, it is a struggle. I mean, thank goodness that we have, this army of people in Lansing and in Detroit that help me navigate that. But I talked to Eric, our private approval person, at least 3 to 4 times a week. And he is having me call to do a peer-to-peer with some other doctor that I don't know. And at least once a week, I'm begging for something. And so, yes.
Why when you get the CAR T treatment or therapy, you don't need maintenance?
Yeah, that's a super good question. So it's the difference between how the CAR T works and how the bispecifics work. So what the CAR T should do is that you get, your T cells and you engineer a gene to kill myeloma. You put it into your T cells. You put it into your live T cells. You grow them in a culture, and then you come into the hospital, they infuse the CAR T cells in you. What should happen is that when those T cells that were taken from your body and they're re-engineered and put back in your body, they should reproduce in your body. So even if you're not getting a therapy like a monthly every 2-week bispecific, you have those cells hunting myeloma every day. So you're actually getting therapy. Even though you're not getting it through the vein, those cells are reproducing and being active in your body. The trick is that for myeloma patients, and that's CAR T, general CAR T. For myeloma patients is a little bit different. And some patients, that is totally the truth, that they have proliferating T cells that are killing the myeloma cells on a regular basis, and you're not coming in for treatment, that treatment is active in your body. For some patients, the first infusion works so well, it eliminates the myeloma to such a low degree that those cells kill themselves off. So those millions and millions of T cells kill everything in sight, and then they kill themselves because they've worked so hard in doing that. But the myeloma is at such a low level that it takes years to grow back. And that the treatment has burned itself out. And so who's who in the zoo, for that, it doesn't matter a whole lot because the outcomes are kind of the same between the two. Yes?
I have a friend that had the CAR T surgery about a year and a half ago. She has now relapsed What is the reason why? Because we thought
that's a good question.
good.
Yeah.
Why did he relapse?
Yes, super good question. So someone had a CAR T years ago, but they relapsed after a CAR T. Year and a half. So why did they relapse? Super good question. Love it. I love all the questions, but this I know about because we just 2 minutes? Because we just talked about this. So, all of us, not all of us, but, some of us had a big meeting in Brazil, in Rio de Janeiro, where all the myeloma doctors sat down and we had our big conference. And that was a big point about the conference is how do people relapse after CAR T? Remember that the CAR T sticks to that BCMA protein on myeloma cells. So, and you have programmed those T cells to hunt BCMA only. The only thing it's hunting for is BCMA. So if those myeloma cells are smart, if someone, God forbid, goes out and says, I'm going to hunt bald men, what am I going to do? I'm going to get a wig. I'm going to say, what bald man are you talking about? I have no idea. I don't know any bald people. And those myeloma cells, they're like, whoa, everyone that has BCMA is dead. Let me change my BCMA by just one little frame shift, just a little click. And all of a sudden, those T cells go right on by and don't even recognize it. So a little mutation in BCMA causes the CAR T, because this is only programmed to do one thing, is kill BCMA. That one little frame shift then causes the myeloma to grow despite everything as BCMA is gone. Which is why they're now building, and they have, and the same thing with bispecifics. Bispecifics hunt BCMA or GPRC5, talquetamab, BCMA, Elran, Linvo, and teclistamab. Any shift, any little mutation in that protein can cause the myeloma to grow, despite the drug. So what they've done is they're building trispecific CAR Ts and trispecific antibodies to beat that. So instead of hunting just BCMA, the new CAR Ts and the new bispecifics will hunt BCMA and GPRC5 at the same time. And so it hits the bald guys and the tall guys. And so now, I can put on a wig, but they're going to say, well, he's tall, out. Or I try to say, well, I'm short now, and have no wig, out. And so and the response rates for the triple pack are really, really high. But they're still very early in clinical trials.
So that requires another operation?
That'll probably, those require the very similar CAR T or bispecifics. To my knowledge, what's furthest along right now are the trispecific antibodies. So those are the ones that are really moving into, in fact, even now, the most further along in that 3 sort of target in clinical trials for myeloma is combining teclistamab, which is against BCMA, and giving talquetamab, GPRC5, at the same time. And when they've given those two bispecifics at the same time, this was really, it's called a redirect trial, and I thought it was a huge deal, because when you give those two together, the response rates are higher than either drug alone. More importantly, the side effects are no different than either one alone. And so you get, twice the benefit without increasing the risk. And the other good thing is that there are other targets being developed, being sought for myeloma. So the FC protein that's on myeloma cells are a target. And they're coming up with new targets because they know that some of these drugs with just GPRC5 and BCMA will eventually fail. And so we need to have new targets for myeloma. Yes. can I?
So if you fail a bispecific, are you ineligible then for a tri-specific? Like, would it be pointless because one of them you've already had in your system?
If the tri-specific includes the protein that it was targeting, so a BCMA and GPRC5, they would probably have, and those are super early trials, but they want people, right now, they want people that are naive to those two drugs. And so but there are, again, novel target ones that will, because everybody knows now that a lot of people in the future are going to have been targeted for BCMA and have failed it. So now the race is on to include more into the repertoire of just not GPRC5, but other targets too. And so the future tri-specific will probably not be a BCMA tri-specific.
Thank you.
So Dr. Cole, I'll bring you a wig when I come on the 20th.
Please. No, I saw myself in the wig and I was like, Lord, I'm happy I'm bald. Can I do 2 more questions and I'll be done? Yes.
The CAR T, when they have 2 medicines. So you was talking about the second line. I can't say it. It's CARVYKI.
Carvykti, yeah.
Yeah. Now that's the second one they introduced. And is that the one that kills both? You was talking about.
No. So that just goes BCMA, yeah. So Carvykti and Citracel, Isodel target BCMA. Yes.
Me?
Yep.
So I have a question. The last physician that was presenting, talking about CAR T and the bispecific antibodies, the graph that he had up, so it looked like it showed pretty clearly that at about 30 months, there are a lot of survivors. 40 to 48 months, it looked like there were very few survivors. And so I really wondered that once you've gone to CAR T, is there something that, I mean, you're talking about tri-specifics, but is there another line of therapy?
Oh, yeah.
If you begin to fail post-CAR T, is there more in the vault?
So GPRC5. And so the GPRC5 bispecific is talquetamab. We're using that right now. If I have a couple people on this next week. There's also a GPRC5 CAR T that is in development. And so, because our unmet need for sure is people who fail BCMA therapies. And so that's what, the big thing that we talk about clinical trials on, and the pointy end of the future clinical trials is what we do when people fail, BCMA-directed therapies. So it's not like we're saying, oh, we're done. I mean, we are really, 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 really working at what we're going to do in the future when the BCMA, when everyone gets BCMA therapies, like everyone's getting CD38 therapies right now, and what are we going to do after that?